dear champs, hope you are good and preparing well for your MRCOG Part 3 exam. Back to Basic, Series May 2025, and the module is Subfertility. Introducing myself, I am Dr. Dinesh, one of the main tier of Team StudyMEDIC, and today we are discussing this module in detail. Subfertility is a very important module which makes the journey of parenthood from dream to reality, and that's the reason the module has to be dealt with all compassion and empathy towards your patients. So, MRCOG Part 3, the last exam, and yes, the victory and success will be yours, and very soon you will be a proud member of Royal College of Obstetrics and Gynecology. So let's start the module of subfertility. The module has total 5 domains: information gathering, communication with the patient, communication with the colleagues, patient safety, and applied clinical knowledge. What each domain specifies: information gathering, where you should be able to sensitively take a detailed history from a couple and initiate timely and appropriate investigations and plan, interpret their results using them, a plan of care, and make them able to seek additional information from the sources which can help them to get the best care. Communication with the patient and families, it talks about whether the candidate is able to communicate with the patient and their families in a sensitive manner around the issue of fertility. Fertility is something which is a social taboo. Investigations and treatment and complications should be explained well, including the legal framework for the treatment in the United Kingdom. Communication with the colleagues, where you should be able to involve the MDT, that is multidisciplinary team approach, wherever it is appropriate, knowing when to refer for a specialist care. It do include the clinical psychologist. Talking about patient safety, able to understand the safety issues involved into the treatment of subfertility, prescribing for superovulation and multiple pregnancies, talking about embryo storage and freezing of the gametes, the legal framework for the assisted reproductive techniques, including the provisions of HEFA, that is Human Fertilization and Embryology Act, for the treatment. In the context of applied clinical knowledge, you should be able to use the evidences critically to inform the management of couples, including the constants of care. For example, in those with a one partner with a child, or age of the partner, that could be a maternal age, same-sex couple, and etc. Understand the contribution of male and female factor to fertility and how these are managed well. So here we'll be discussing about 3 stations, how it should be performed, and what are the domains where your marks will be counted for your success. So station 1, this is a stimulated patient task where you will be assessed for the communication with the patient, information gathering, patient safety, and applied clinical knowledge. Scenario: Tamara Joan was referred to the gynec outpatient clinic by her general practitioner. The general practitioner later is available. You have been asked to see and counsel her. You have 10 minutes during which you are expected to take a relevant history, address her concern, propose an appropriate management plan for her. Make a note: regarding the examination finding, her blood pressure is 110 by 75 millimeters of mercury, BMI is 35, and considering the remaining examination finding as normal. Here is a referral letter from the general practitioner. Dear doctor, I would appreciate your valuable inputs about Mrs. Tamara. She and her partner, Mr. Alfred John, has been trying for baby for past 3 years, and her last visit, her blood pressure was normal, her BMI was 35. In addition to advise her weight, I have requested a scan, a fertility hormone profile, HSG, and a semen analysis. Semen analysis came normal. She and Mr. John were both informed about it. Regarding her investigations, Tamara John is 37-year-old. Her NHS number: hormone on day 2 of her menses. The FSH is 4 international unit per liter. LH 10 international unit per liter. Day 20 of progesterone is 15. The transvaginal sonography performed suggests that normal uterus with endometrial thickness of 6 mm. Both ovaries showed 12 to 14 peripheral small follicles, 9 to 11 mm each. HSG findings are normal uterine cavity and normal bilateral spill. US, Dr. Homer Simpson's MRCGP. Moving ahead, how exactly this station should be started? There are the domains, the communication with the patients. So have a proper appropriate introductions. Good morning, I'm Dr. Dinesh, one of the doctor covering the clinic. I believe you are. Take the name of the patient, and the name of patient is very important for you to address during your consultation to make a rapport. Or you can say that, may I check your name and age, please? How would you like me to address you? Or how are you today? During that initial visit, you should show the warmth and the open attitude towards the discussion. The scope of consultation has to be discussed. I have gone through your GP later, and I believe that you're trying for baby and some investigation has been carried out. I wish you the best for the treatment. Do you have any other concern? These are the ways where you can know and you can have good rapport with your patients and you can understand their concerns better. She may say that my husband investigations are normal and I'm afraid that means the fault is mine, where you need to show the understanding or something like that this journey is not alone, it's the journey of together or with the partner. I can understand your concern, but it is not about who is okay and who is not, but rather to see what could be done best. And we are here to best support you. So set your agenda. Is it okay if I ask you a couple of questions that will be help me in discussion? Then we can go through the investigations to be carried out. I'll make sure to address all your concern and explore your options. I'll supplement our discussion with some useful leaflets. How does it sound? And if she's okay, definitely with her permission, you can proceed your plan. Make a note of it, try to avoid medical jargons. Invite questions and have attentive listening. Frequent checking of their understanding and have eye to eye contact and good body language makes the beauty of the station on a very good note. Use the drawing in an order to explain certain terminology, as in this scenario you can explain the PCO by making a small drawing, and this is how we are making our communications to be more effective. And at the end of this the session you can conclude by recapping whatever you said and whatever the patient has confirmed with her history, and schedule her another appointment as early as possible. Provide patient information leaflets, support groups, and yes, referring back later to the general practitioner that what has happened in this consultation visit, so that the care of continuity should be maintained. And this how we'll be covering the stations in terms of communication with the patient. So let's talk about how the information gathering domain should be covered. So Tamara, you and Mr. John have been trying for baby. Can you tell me more about this? So very quickly, she'll be trying to explain what treatment option they have explored or what are their main concerns. If not addressed, you need to ask about her duration, the past conception details, whether they have tried any form of fertility treatment or ever had any other test done to investigate the cause of fertility. During this information gathering, certain points you need to signpost. There are a couple of questions that I ask all my patients. May sound intruding. May I? Then she will allow you or she can give you the confirmation that you can proceed with those questions, and then ask about her sexual history, how frequent do you have intercourse or any difficulties so far, and complete the rest of the history template very quickly, because yes, the time is limited for 10 minutes durations only, where history taking should be covering within initial 3.5 minutes. Talking about the gynae history, can you tell me more about your periods in an order to rule out pain, intermenstrual bleeding, in the postcoital bleeding, which are nothing but the red flag signs, and do ask about their smears. It may be relevant to ask at this stage about other features of PCO, at least excess of body and the facial hair, because yes, you will understand the type of PCO. You can explain that you need to ask about other symptoms that do occur in a woman who experiences irregular periods, to avoid a certain question from the role player about why, or rather than making them puzzled. Do you follow with your general practitioner for other issues or any previous surgery? Do you smoke, drink alcohol? What do you do for a living? How is everything at home? Ever been bothered about? And this is how you are commenting about the mental health too. Are you on any medications right now? She must be having the prenatal supplement like folic acid. Make a note of it. Are you allergic to any drug, which is very, very important on a patient safety point? If she say yes, then yes, you need to ask about how severe it is and have a habit to say that. Make a note. I'm making a note of it so that she will be understanding and it has been understood well that yes, candidate made a note of it. And recap quickly whatever it has been mentioned in history, as we know that a further first primary conclusion come after the history. Once you do the examination, you will come to the final conclusion of the diagnosis. So recap quickly. Anything else that you think I need to know? Sometimes during the hurry we might skip out certain important points, and somewhere it is instructed to the role player to prompt the candidate if they miss out something, so this question makes them very easy. Regarding BMI and weight, a patient who is on higher side of BMI and weight, they may not like certain aspects about discussions, and that's the reason you need to signpost. You need to take them into the confidence before you discuss. We keep to ask all our patients about their weight as it is very relevant. What do you think about yours? Then she may say that yes, my weight to height ratio, or I'm chubby since from the child. So then you can proceed. There is some sort of signpost here, but she may show some irritation. In that context, you need to apologize and again explain why you ask these questions. Research showed that the ability to achieve pregnancy might not be as smooth as it should be in a woman whose their weight is not matched for their height. And if this is the case, losing the tiniest amount of weight may be of difference. There are a lot of ways to do so. If you wish, may I? Then definitely she will allow you. If she come with a reason for being unable to do exercises after some sort of trauma or road traffic accident or fracture, then show the understanding to that, and this will also count in your communication skill, which is very important over here. Talking about the domain about applied clinical knowledge particular to the stations. So how you explain the investigation, check her background knowledge about the investigation. Whenever you're reading about any investigation report, confirm the name, age, and date. Then talks about the investigation reports in an easily understanding fashion. So it makes sure that whether you understood and whether you will be able to explain it well to your role player. The tubes, the passage that allows eggs to be fertilized and move to the womb, are patent and open. This is how you explain about the HSG report. The hormones and the scans are telling that you are likely to have a condition called PCO or whatever the condition that you could see from that sonography, and do check her understanding. Ever heard about it? Then definitely she may say, she may not, or she might be having some little idea. Then you can explore the condition in detail in a patient friendly manner. It is where eggs for some reasons get trapped in a egg basket and not released as regularly as they should be. Women with this condition can experience a variety of things, including the irregular periods, finding it difficult to conceive, finding it difficult to lose the weight. And this is what PCOD. Am I clear so far? And this is how you are checking the understanding. She may ask you, is it serious? Then definitely. While it may be bothersome, it is not necessarily serious. It can be fairly common. How fairly common? Then you need to explain that up to 1 in 4 women and women with this condition can be more vulnerable to the diabetes and high blood pressure. With a healthy lifestyle and individualized care plan targeting its effects and good follow-up, the serious effects on health are uncommon. I can provide you with a helpful patient information leaflet produced by our Royal College that tells more about the long-term health issues associated with these conditions. So now we have two issues to be discussed. The one is irregular period, and second, trying to get pregnant. A healthy lifestyle, including the healthy diet and exercise, to optimize weight is of paramount importance, and not only it help with the periods and to get pregnant naturally, but it will help to ensure a safe pregnancy with a good outcome for you and your baby. What do you think, Tamara? And definitely Tamara will be in your favor and you can proceed. Talking about dietitian, a slim club member, she may say that the exercise might not be as easy now due to a previous trauma. Offer a meeting with a specialist doctor who can discuss the weight reduction medicines and surgeries, their efficacy and safety when they try to have a pregnancy, and after that, the outlook of pregnancy after such an intervention. So, all the pros and cons has to be discussed well with the patients. For the lining of womb, as she is having a regular period, as it is not shedding on, so to avoid the sinister changes, it needs to be shaded at least once every 3 to 4 months. There are plenty of options to provide this that doesn't interfere with your wish to fall pregnant. A fertility clinic can discuss the following options. They usually offer a step ladder pattern of treatment. There are tablets that can increases the chances of your ovaries to release the eggs. So she mailed that she must have tried some medication. It could be a metformin or it could be a clomiphene citrate. If it is not effective, there are injections for the same purpose, and both needs to be seen under the supervision to monitor the complications. Sometimes, if both are not effective after a while, or maybe a follow-up is will become very cumbersome for you, then a keyhole surgery to make a tiny holes in your ovaries may help them to release the eggs regularly. And lastly, a test tube baby may be an option for those women whose weight is optimum for their weight to height and couldn't achieve a pregnancy after even 2 years of trying, or whenever the clinical indication make them move towards the IVF as an option. And at the end, you have to recap whatever you have discussed so far and close the station. And this is also counted in your communication skill. Meanwhile, continue on a folic acid, regular coitus, and conclude your station with a good approach. In the station, what about the patient safety? Very importantly, when you are reading the report, the confirming the name and age before delivering the results, it's very, very important. Why weight loss is needed? Very importantly for her own health and if she was pregnant. To second on the importance of the folic acid tablets to be offered by general practitioner, how to lower the risk of endometrial pathology, when to seek advice, screening for depressions, the multidisciplinary team approach, which include the consultant, the dietitian, counselor, the fertility specialist, if required, a bariatric surgeon, and general practitioner. And that's how it completes the stations for the patient safety. So, at the end of the time, what are the resources will be required for the station? The long-term consequences of polycystic ovary syndrome, as given by RCOG. A polycystic ovary syndrome, what it means for a long-term health concerns by RCOG. The fertility problem assessment and treatment as a NICE guidelines, and fertility problem assessment and treatment, the information to public as a part of NICE guideline. So these are the resources that we'll be utilizing, and certain patient information slips given by the college will be handed over to the patient for their easy understanding. And this is how we are completing the stations about PCO or irregular cycles or anovulation. So understand these are the way where we'll be finding out a very important asterisk points when candidate is performing the stations. And that's the reason the communication is very, very important. When we are doing the communication, understand there is a difference between the communication and delivering the lecture. Lecture is a one-sided method where we are not inviting the question, we are not checking the understanding. But during the communication, yes, it is expected that you invite the questions, you talk to your role player, let them to explore their more concerns, and that's how the communication always happens between two people. So I understand in MRCOG Part 3 exam, you already cleared your Part 2, you're all thorough with your applied clinical knowledge. But yes, in that 10-minute span, whatever is expected, that only you're supposed to explain to the patients, and if time permits, then only rest of the other informations if the role player is interested. At the end of the time, a complete session definitely put the smile or satisfaction attitude on the role player's face, and that makes your stations to be on a perfect note. So going ahead with station number 2, the candidate instruction. This is the patient stimulated task assessing the information gathering, communication with the patient and their partner, patient safety, and applied clinical knowledge. You are ST5 doctor in a repetitive medicine clinic, assisting your consultant in reviewing a couple struggling with a primary infertility for over 2 years. Mrs. Lauren Pitt, a 32-year-old teacher, and her partner, James Pitt, 34-year-old teacher, have been undergoing fertility investigations. You have 10 minutes to obtain a targeted fertility and clinical history. Explain the test results, including the tubal factor infertility and hydrosalpinx. Discuss the management plan, including the laparoscopy and its implications. Understand in these questions and in every station, it is always important where you should look into. You have 10 minutes to perform 1, 2, 3, whatever the questions are there. Make sure that in that 10 minutes, those questions and those things has to be touched upon, because the domains are marking about the asterisk point from these questions, and this is very, very important over here. So let's talk about information gathering. So this domain assess about the structure, relevant history taking, focusing on a fertility issue, the menstrual cycles, the lifestyle factors, and the partner's role. There are a couple of things as a part of key expectation to pass the station in terms of information gathering. Note there are certain couple of things that can be asked by the role player during the consultation. So the question about what is wrong with my tube? Does this mean that I can't get pregnant naturally? I have never have any pain or infection, so why my tube was blocked? Is there is any way to unblock the tube? Is it really necessary to take some sort of treatment like a laparoscopy? And what does it means to me? Does removing the tube mean that I will never get pregnant naturally? Or What are my chances of having the pregnancy after the surgery if you think about this laparoscopy? So these are the questions that are routinely been invited by the role players. So always give a scope of communication and let your role player to explore their concerns. Coming to the history, the menstrual history and ovulation history is very, very important, as the stations do talk about a targeted history, ask about the cycle length, the regularity, and the menstrual flow. Explore the ovulation symptoms, example, mid-cyclic pain, cervical mucal changes, or ovulation taste. The fertility and sexual history. Again, whenever you are asking the sexual history, always do signpost that clarifies the duration of attempts to conceive and frequency and the timing of intercourse. Ask about the previous surgery, the miscarriages, and assisted conception attempts, whether they have made so far. The symptoms suggesting about the tubal factor infertility. So ask about the pelvic pain, the history of sexually transmitted infection, the previous pelvic infections, the abdominal surgeries. Screen for the endometriosis like symptoms like painful periods or painful intercourse. Do talk about the lifestyle and the partner's factor. Inquire about diet, the physical activity, smoking, and alcohol habits. Explore the partner's health, the lifestyle, and understanding about their fertility issues. Medical and family history. As a part of targeted history, the screening for diabetes, thyroid, and autoimmune conditions. Do ask about the family history of infertility, endometriosis, and any particular tubal disease. Then talking about the communication with the patient. So this domain assess with the empathy, clarity, and ability to explain the medical concept in a patient-centered way. The in key expectation to pass this station or this domain, the building a rapport and addressing their concern is very, very important. Acknowledge the patient distress about the difficulty in conceiving. Use the empathetic tone when discussing about the fertility concern and potential delays. Potential delays, sometimes it can happen during the OPD or because of the waiting times, or you might be busy with some procedure. Always address that and make sure that you are giving the priority to your patients so that they should feel valued. Explain the medical condition in a layman's term. For example, the hydrosalpinx as the explanation. Your test shows the tubes are blocked, the tube is swollen and filled with the fluid, which can reduce the fertility and do increases the chances of miscarriage. Tubal infertility and conception. The fallopian tubes are essential for conception as they allow the sperm and eggs to meet. With one tube open, the natural conception is still possible, but hydrosalping can impact the success. Seepage of such a fluids into your womb may dislodge the implantation or attaching of your baby inside the womb. Addressing the misconception and setting some expectations. So clarify that hydrosalpinx may impact the fertility even if one tube is open. Otherwise, they do feel that even if they do go for surgery, it's not going to affect their fertility outcome. Explain that the laparoscopy will help determine the best treatment approach because you can assess the extent of the tubal damage because of the hydrosalpinx. Handling the emotional reactions very professionally is very important over here. If the patient is frustrated with the delays, explain, I understand that waiting is difficult, but confirming the extent of tubal damage help us to choose the best treatment and avoid unnecessary delays. And it's very important because even if it is a surgery, they do have to wait for a couple of days and they have to process ahead, and they may feel that why the time has been wasted for this investigation, why can't they try naturally? But yes, they can have options, but again, we have to always tell the pros and cons in detail. Moving ahead, if the patient insists on immediate treatment, then clarify that we need to ensure we fully understand the condition of your tubes before deciding on treatment. This helps us to improve the chances of success because they may ask you to go for certain medications only or a conservative approach, or leave the tubes as like it is and let them to have a natural and advise them how to conceive naturally. But yes, we need to address this concern in detail. Encourage the patient participation and questions. Check the understanding throughout the consultation and ask the patients whether they still have any remaining concern because it is very, very important over here. Talking about patient safety, this domain assesses whether the candidate identifies and mitigate the risk, avoid the inappropriate treatments, and ensure the comprehensive patient safety. When you know that there is a gross hydrosalpinx, the medications will not work, and still you are offering a medication does not sound a good or patient safe plan. Now, what are the key expectations for passing this domain? Ensure the correct investigations before your treatment. Recognize the need of laparoscopy to confirm the hydrosalpinx and assess the tubal patency. Explain why hydrosalpinx may require surgical interventions before fertility treatment. Discuss the risk of hydrosalpinx on fertility and pregnancy. Hydrosalpinx can reduce the implantation rates even in IVF. If the tubes is severely damaged, and leaving it in place may reduce the success of fertility treatment, and yes, it do put the ill effect for your health. Explain why surgery may be needed. If hydrosalpinx is confirmed on laparoscopy, removing of the tube can actually improve your chances of conception, gives the assurance. Confirm no immediate need of IVF unless it is necessary. If the laparoscopy shows that one tube is healthy, we may try naturally conception. If both tubes are blocked, then definitely IVF would be the best option. And after this thorough discussion, document the plan and follow visit appropriately and arrange the follow up for the consultation post laparoscopy too. And ensure the clear documentation of fertility history and the steps. In the context of applied clinical knowledge, this domain assesses the interpretation of the fertility investigation to the patient, whether the patient understands well, the clinical reasoning of those investigations, and adherence to the guidelines. So, in an order to complete this domain, there are expectations for a passing reason. The interpret the investigation results correctly. Identify hydrosalpinx as a cause of tubal factor infertility. Recognize why further assessment is necessary and correctly interpret the semen analysis as it is normal. And follow up with the evidence-based management for tubal factor infertility. So what that includes, the first line is laparoscopy to assess the tubal function. Second line, salpingectomy if the hydrosalpinx is very severe. And third line, that is the IVF, if the both tubes are blocked or after having the failed attempts of natural conception. And discuss the treatment options very clearly. Explain them about the natural conception versus assisted reproduction based on the laparoscopic finding. And clarify why surgery may be beneficial before the IVF in order to fetch the success. And this is how you are completing about your station. There are particular things that's to be avoided in the stations. Specifically, directly do not jump onto the test result. It may make the patients feel unheard. Being dismissive about her concern always increase the frustration and distrust toward the course of treatment. During your consultation, yes, you need to explain the medical terminology in a patient friendly language. Very importantly, the hydrosalpinx, the function of the fallopian tubes. Not explaining the risk of keeping the hydrosalpinx leaves your patient confused and they may not come to the conclusion. Failing to emphasize IVF as a backup option, definitely, if you don't do that, it will put the anxiety because they may think that they will lose the journey of parenthood. And yes, it is very important for us to summarize. During the summarization, you can clearly say that your test results suggest tubal factor infertility due to hydrosalpinx, and we recommend laparoscopy to assess your tubes and improve your chances of pregnancy. If needed, we will definitely discuss about IVF as an option after the surgery. How's that sounds for you? And definitely, if she has many more concerns, she will definitely open up and she will clear with you. And yes, at the end of the time, you have to make sure that you'll be documenting the plan of care into the notes, and yes, providing the patient information leaflet, and come to the conclusion at the next visit, even if it is possible not to conclude at this visit. So this is how we'll be completing with the station. Now moving ahead to the third station. Candidate instruction. This is the stimulated patient task, assessing the following clinical skills, which include the information gathering, communication with the patient and family, patient safety, and applied clinical knowledge. You are ST5 doctor in Subfertility clinic. Your consultant has asked you to review Mr. James Adam, a 34-year-old patient, regarding his semen analysis result. Mr. Adam and his wife, Sally Adam, 32-year-old, have been trying to conceive for 3 years without success. Sally is not present today, but she has given a written consent for you to discuss her reports with Mr. Adam. His semen analysis has revealed azoospermia, absence of sperm in ejaculate. Mr. Adam is unaware about this finding and has come with expecting advice on their fertility journey. Your task is to take a focused subfertility history from Mr. Adams, explain the likely cause of subfertility based on the test result, discuss the management options in a very sensitive and provide them guidance. You have 10 minutes to perform this task. Again, note there are three concerns over here which has to be expected that candidate should meet in that 10-minute span. And yes, we have to touch upon with these questions very important in the upcoming 10 minutes. So again, here it is very clearly mentioned that she has given the consent for discussing her reports to her husband. So again, if this you ask during the consultation, have we your wife has given the consent, or if she's not there and that's the reason we are not able, here your situation awareness will be put you at a shortage. If it is already mentioned, then yes, you can proceed and save your time and complete your targeted station in a 10 minutes fashions. So, communication with the patient in this particular station. It assesses how well the candidate build the rapport, explain the medical concepts clearly, and manage their patient's emotions. All results may not be pleasant, all results not need to be very bad. When I see a station of Azoospermia and when the candidate performs, the always say that it is very unfortunate and I'm sorry to the bearer of this news. Understand one thing, Azoospermia is a journey of exploration. You need to confirm with couple of more tests and explore the other options to have the baby, but doesn't mean the end of the world. And yes, that's how you need to be very assured with this. Definitely for a oncology station, when you are dealing with the news of cancers, you can use those words appropriately, but these stations may not need that. So key expectation to pass the station. So break the news with the sensitivity. Use the empathetic language to introduce azoospermia as a diagnosis. I have reviewed your semen analysis results and I need to discuss with them with you. Acknowledge the shock allows the patient to process the news because it may not be pleasant. He may be surprised, he may be angry, or he may shout out for some small reason. I can see this is unexpected. I want you to reassure you that we have options and I'll guide you through them, and that makes them assurance which is very clear on their part. Avoid blame and reassure the patient that this is not something you caused and we are here to explore the solutions together. May I proceed? And that definitely the role player feel very confident with the candidate and you can proceed ahead with the further discussions. Explain the azoospermia in a layman's term. Define the azoospermia simply that this means that there are no sperm in the ejaculate. But this does not necessarily mean that you cannot have your biological children. Check the understanding about whether he understood well. Would you like me to go over any part again? Sometimes during the explanation of azoospermia, you can make a small drawing where you can making that the substance coming from the brain acting on the gonads which are down there. Gonads is just like a factory where the sperms are getting produced and coming through the organ of copulation that is called the penis. And if there is a blockage into the outflow, definitely we can clear the blockage or we can directly take the sperm from gonads which are down there by means of small procedure that is called as surgical sperm retrieval. So very quickly you can explain about obstructive and non-obstructive azoospermia to this patient, so and make them realize that exactly that azoospermia is not the end of this, but yes, we can retrieve the sperm by a number of techniques too. Encourage the patient to ask the question and express the concern. Ask, how are you feeling about this? Is there's anything on your mind? Definitely they will be having a frustration or negativity, and you have to explore that how much they are taking the toll of it's on their mind. And sometimes some patients might be having some idea about it and they might be just come here for the reconfirmation, and there could be some different agendas like exploring about the donor options and their safety. So you need to ask in detail. If the role player is already having a clear idea about some particular medical condition in detail, again explain that thing will definitely consume the time from your station. Respond to patient and non-judgmentally to concern of about the masculinity, erectile dysfunctions, and fertility. In information gathering, this domain evaluates how well the candidate takes the structured fertility history, explore the risk factors, and identify the causes of azoospermia. So, in order to pass the station, the comprehensive fertility history taking is very, very important. What it includes: how long have you and your wife been trying to conceive? Have you ever fathered a child before? Have you ever had previous infections, surgeries, or testicular trauma in the past? Explore the symptoms which are suggestive of the hormonal and testicular dysfunctions. Have you noticed any changes in your testicular size, pain, or swelling? Do you have any difficulties achieving or maintaining an erection? Have you experienced any changes in body hair and body hair growth or breast changes? Sometimes gynecomastia that you might need to rule out in an order to rule out some particular syndromes. Identifies the medical and the lifestyle risk factor. Before that, whenever you are asking about sexual history and these are some very intimate questions, always signpost. Identifies medical and the lifestyle risk factor where the diabetes history and how well controlled. So how well is your diabetes control, and have you noticed any numbness or tingles in your hands and feet? Sometimes this could be the reason of having the erectile dysfunctions or might be you're having the azoospermia. Family history of infertility or genetic condition. Has anyone in your family had a fertility issues ever? Do talk about the smoking, alcohol, recreational drug use, and excessive heat exposure so that you'll coming to know that what are the recovered risk factor or reversible risk factor. Talking about the domain about the patient safety and risk assessment. This domain evaluates the candidate's ability to identify red flags, recommend the appropriate investigations, and ensure the patient's safety. So, the expectation to pass the station always recognize the need of further investigation. Request about repeat semen analysis to confirm the azoospermia as early as possible, and if there is a one parameter or if it is a oligosenoteratozoospermia, yes, then 3-month time period will be required. So order a full hormonal panels as it is a azoospermia, which include the FSH, LH, and testosterone. And as I explained, that the substance coming from the brain acting on the gonads, which is down there, which is like a factory. And that way you have to explain that why it is needed, why it is important for us to know. Prolactin, estradiol level. Request about the scrotal ultrasound to check for testicular size and consistency, obstructions, vas difference, or is absent or varicocele is present, and sometimes transrectal ultrasonography might be helpful for this. Identify the red flags and when to refer. Suspect the genetic cause if it is, order a karyotype and CF that is cystic fibrosis gene mutation. Severe hypogonadism and pituitary disorder, then definitely we need to inform and refer to the endocrinologist. Do think about the testicular failure, maybe very high FSH and low testosterone, counsel about the poor prognosis of sperm retrieval, and that's how you'll be explaining well to the patient. In the applied clinical knowledge, this domain will assess how well the candidate explains the treatment option and create the structured management plan. So, as a part of key expectation to pass the station, explain the possible treatment pathways very clearly. If it is obstructive azoospermia, sperm retrieval via PESA, that is percutaneous epididymal sperm aspiration, or TESA, that is testicular sperm aspiration technique. Use of ICSI, that is intracytoplasmic sperm inoculation or injection, or IVF to fertilize an eggs. If non-obstructive azoospermia, then what is the medical management? If it is because of the hormonal imbalance, which if it is correctable, you can try for that. Sometimes the hypogonadism it could be the one of the cause. Microtesa, that is the testicular biopsy to find the sperm for the ICSI, can be performed, or donor sperm or adoption if no sperm has been found. And these are the options that you need to explain to the patient. Explain the realistic success rate. In some cases, we can find sperm surgically, however, we will only know after further testing. Provide psychological supports and resources to the patient. Would you like to involve your wife in the next appointment? We can arrange the counseling services if you'd like to have additional support because it could be one of the distressing conditions. But yes, always give them a support to this patient. And this is how we'll completing the station of azoospermia. Again, MRCOG Part 3 is a very wonderful journey where you will be assessed on these 5 domains. Make sure that you will be touching about each domain well. Always read your stations in detail and see that in next 10 minutes what is expected from you. The college is very clear. It is not possible for every consultation to wind up within that 10 minutes, but there are particular concerns that has to be addressed in that 10 minutes. That is very, very important. Always start your station with a good attitude, with a positive posture, and end with a warmth and proper recap of whatever you have discussed, and try to make a note of it and schedule your appointment, discuss with your consultant. That makes that station to be completely informed to everyone. And this is how we are completing with the stations of Subfertility. So these are the 3 demo stations that we have discussed so far as per their domains and what are the expectation for the passing candidate. So here we conclude with the Back to Basics series about Subfertility module. Wishing you all the best with lots of love and happiness. I'm Dr. Dinesh, one of the mentor of Team Study Medics.